Good evening, everybody. Today, my topic of discussion is recurrent lung collapse in a ventilated child. Sorry, there is some problem with the slide. I'll just. Now, continuing with my topic, a short introduction about atelectasis. It was first described by Lenach in 1819, which means imperfect expansion. It originates from the Greek word ateles for imperfect and ectasis for expansion. It might be due to a congenital defect, which is known as primary atelectasis, but it is mostly used to describe the collapse of lung tissue, which might be acquired due to some cause. Incomplete expansion of a lung or portion of a lung, airlessness of a lung that had once been expanded, and collapse of a lung can define atelectasis. Now, a short overview of the causes of pulmonary atelectasis. It might be due to an intraluminal bronchial obstruction by a foreign body. It might be because of the compression of a bronchus by a vascular link, lobar emphysema, some lymph nodes, or cardiomegaly. It might be due to bronchial inflammation because of bronchial asthma, any infection, pneumonia, cystic fibrosis, ciliary dyskinesia, immunodeficiency, and chronic lung disease of the newborn. Postoperative in cases of esophageal atresia or tracheoesophageal fistula repair. Other causes might be bronchial wall involvement due to tracheobronchomalacia, airway stenosis, bronchiectasis, bronchial tumor. Surfactant dysfunction, as it is most commonly seen in RDS of the newborn or in ARDS, where there is secondary surfactant deficiency. Compression of the lung tissue by cardiac enlargement, pneumothorax, hemothorax, lung tumor, or chylothorax. And primary atelectasis due to congenital malformation. The clinical features usually depend on the extent of the atelectasis, the rate of formation, the age of the patient, and the etiology or the causative illness causing the atelectasis. Now, I would go on to a case-based discussion, which we had encountered in our ITU, where babies were getting recurrently ventilated for the few causes that I am going to discuss. For the first case, we had a 2-day-old baby boy with a diagnosis of PTGA intact IVS, arterial switch operation done on day 6 of life. The child faced recurrent collapse of lung in the post-operative period, leading to multiple intubations and extubations, and eventually led to prolonged ventilation. Eventually, the child grew Klebsiella in ET culture, ET secretion culture, and the child was treated with sensitive antibiotics for appropriate duration of the time. Appropriate ventilatory management were undertaken, and supportive management with chest physiotherapy, positioning of the child, lung toileting, nebulized online bronchodilators were administered. And the child recovered slowly from the recurrent collapse, and we could extubate the child, and the child was finally successfully extubated after the 4th attempt. And after completion of antibiotics, the child was weaned off NIV and oxygen, and we could send the baby home by the 15th POD. In the second case, I would like to discuss a 1-day-old baby boy born at 31 weeks of gestation, weighing 1.4 kg, who developed respiratory distress soon after birth. The diagnosis of RDS was very obvious from the chest X-ray. The child was mechanically ventilated soon after birth, and it was managed by appropriate ventilator strategy. Surfactant was given intratracheally, and in this baby, we had to go for 2 doses of surfactant because the first dose of surfactant didn't improve the baby as expected. After the second dose of surfactant, we could achieve improved oxygenation and ventilator parameters could be reduced and we could extubate the child. This is the X-ray after the second dose of surfactant and extubation. And this child also was weaned of respiratory supports quite easily after we had extubated, required oxygen for another 5 to 6 days. After that, the child was weaned of oxygen and we could send the baby home. Another case is of a 3-day-old baby boy diagnosed with VSD and coarctation of aorta. In day 2 of life, the child was transferred to us. Initially, coarctation dilatation was attempted in the cath lab, but due to inadequate results, the child went on to VSD closure and coarctation repair on day 5 of life. We faced repeated failed extubations in this kid in spite of adequate cardiac repair, and cardiac echo was perfectly fine. We also experienced post-operative stridor in this child, and there was recurrent collapse post-extubation which led to re-intubation of the child. In this case, we performed a fiber optic bronchoscopy which revealed a severe tracheobronchomalacia with subglottic stenosis. In spite of adequate conservative measures, the child could not be extubated. And even if the child was extubated, the NIV could not support the child. And the option of tracheal surgical interventions for tracheomalacia subglottic stenosis is very limited in our setting. And unfortunately, we lost the baby and the baby could not be salvaged. In my fourth case, I would like to discuss a 6-day-old baby boy with TGA intact IVS, arterial switch operation done in day 9 of life. 2 failed extubations were experienced and extubated to CPAP, but there was persistent tachypnea and right lower zone collapse with elevated right dome of the diaphragm. Sepsis was ruled out by consecutive negative cultures. We suspected a diaphragmatic palsy, unilateral, and USG chest and fluoroscopy was done, which consolidated less movement of the right side of the diaphragm. The baby required prolonged CPAP support, prone positioning, splinting of the diaphragm, chest physiotherapy, and adequate nutritional support. And after prolonged ITU stay, the child could be recovered from the tachypnea, oral feeds established, and oxygen support was also weaned off. And this X-ray is at 3 months follow-up, where we see that the child has a well-expanded lung and normal position of the diaphragm. The fifth case is a 9-month-old baby boy diagnosed as complete AV canal defect, severe PH, was admitted preoperatively with bronchiolitis. The nasopharyngeal aspirate detected influenza B and parainfluenza. The child was started on oseltamivir, but the child developed spontaneous pneumothorax as a consequence of the viral pneumonia. ICD was given. The child was extubated to CPAP but was re-intubated in view of pneumonia and intractable heart failure. The team decided for a high-risk cardiac surgery, and after the cardiac surgery, we could control, since the heart failure features were controlled, we could extubate the child on the second post-operative day, required NIV for another 3 days, and oxygen was stopped by another 5 to 6 days. And oxygen was stopped finally by the 9th post-operative day. The post-operative period was uneventful, but in the pre-operative period, the child required two intubations for persistent pneumonia, pneumothorax, and intractable heart failure. Now, to summarize my topic, atelectasis is not a disease, but sign of a disease. The treatment is etiology specific. Primary atelectasis is due to congenital malformation and may require surgical interventions in most of the cases. Atelectasis due to airway inflammation resolves spontaneously with therapy within a few weeks. Inhalation therapy by bronchodilators, racemic epinephrine, may help in loosening the mucus plugs and dilating the airways. Chest physiotherapy, positioning, vibration, suctioning plays an important role in resolution of the atelectasis in addition to our ventilatory strategies and antibiotics. CPAP with increased PEEP of ventilator is helpful. Antibiotic treatment. Fiber optic bronchoscopy has both diagnostic and therapeutic uses. In long-standing atelectasis, which has severe lung pathology with formation of bronchiectasis, it may be susceptible to recurrent bacterial infection, and in some cases, resistant cases, lung resection might be useful. Anti-inflammatory therapy, immunosubstitution in specific cases is helpful. Thank you for your patient listening.